Welcome and thank you for joining us for tonight's webinar, Folklore in Fact, Supporting Neurodiverse and Gender Diverse Young People Who Have Co-occurring Mental Ill Health. Before we begin, I'd like to acknowledge the traditional custodians of the land that I live and work on. For me on the Central Coast, that is Darkinjin land. I'd also like to pay respect to elders past, present, and emerging. My name is Sydney and I'm from the PHN education team. As you'll see, we have a wonderful crew with us tonight. I'm joined tonight by Dr. Yolandi Goodyear, who is a consultant psychiatrist with the Hunter New England LHD and the specialist for gender dysphoria at the Maple Leaf House. Dr. Georgia Page. I know, I'm so close. Dr. Georgia Page, who is a GP at Your Family Doctors in Arana. Dr. Gordon Lau, a GP at Mingara Medical and Headspace. Olivia Gregg, who is a clinical nurse consultant with CAM Central Coast. Sandra Fitzgerald, Health Pathways Clinical Editor, and Erica Drew, Central Coast Health Pathways Manager. Now, a few things to let you know about this session. It will be recorded and available for you to view in our education library in a few days' time, as well as a copy of the presentation slides. As attendees, your camera and microphone are automatically disabled. However, if you have any questions throughout the presentation, we encourage you to pop them in the question box, which you will find located within your control panel. After Yolandi's presentation, Dr. Page will facilitate these along with Gordon at the end. Now, once question time has finished, Sandra is going to speak about the clinical pathways, and then Erica will demonstrate the Central Coast request pages. And then after, an evaluation will come to you directly when this finishes. Your feedback is extremely important to us as it enables us to provide future education. This session is also accredited through RACGP for 1.5 hours of education. I'll upload this next week, so you'll find that in your dashboard. Now, it is my great pleasure to hand over to Olivia Gregg.
Thank you, Sydney. Good evening, everyone. My name is Olivia Gregg. I'm the clinical nurse consultant and GP liaison for the Central Coast Local Health District and Child and Adolescent Mental Health. It is with great pleasure that I introduce Dr. Yolandi Goodyear to present tonight. Central Coast is absolutely privileged to have her as a presenter, and so am I. Thank you very much, Dr. Goodyear. Over to you.
Hi, folks. What a lovely introduction. Thanks, Olivia. Okay, so before I start, I would just like to acknowledge anyone in the virtual room who has a history of mental ill health or who is a carer for someone with mental ill health. And I'd also like to give a shout out to anyone who is neurodivergent. Or who cares for someone who is neurodivergent. I've tried my best to make the slides as respectful as possible, but please feel free to tell me if I didn't do that, and because then I can also learn how to do it better. So my name is Yolandi. I'm a child and adolescent psychiatrist, and my main job is at Maple Leaf House. My pronouns are she and her. So Olivia asked me today to talk about the intersection between gender diversity and neurodiversity, and then add in a sprinkling of how to manage co-occurring mental ill health and risk. I'll try and cover all of those. I might stop on some slides just to talk a bit more, but other slides I might just skip over just because I'm trying to keep an eye on the time as well. Okay, let's get cracking. There we go. Now, these are a range of statements that come across in gender medicine often. They are, have a look at them and test yourself and kind of see how many of these would you think are facts and how many of these would you think is folklore. So gender diversity cannot be diagnosed when someone has autism. Kids with autism think they're gender diverse because of sensory preferences. I like certain types of clothes, so therefore I have to be. Gender identity is always part of the rigid and repetitive behavior of autism. Trans kids need to meet specific criteria of maleness or femaleness to be considered trans enough, i.e. you have to be the boyiest boy who's ever boyed, or you have to be the girliest girl who's ever girled. Trans kids need to cease all symptoms of mental ill health to qualify for gender affirming care. Gender affirming care means You get what you want as soon as you want it. Gender affirming care means the doctor tells you what treatments you're going to get. And transgender young people are mentally ill. And if you just treat that properly, they'll stop being trans. And then, particularly heinous one is kids with autism fail at being a boy or a girl, and then they decide to try it on another gender. So if you have a look at those, you know, I kind of did spoil it with the last one. But yeah, these are all bad. These are all fake. None of this is true. And I hope to sort of untangle those a little bit while we talk. A lot of the times in the gender medicine debate, I think sometimes we trip each other up because we don't all mean the same thing when we use certain words. So that's why you'll see at a lot of gender talks, people put in the definitions of things just to kind of, so that everyone's sort of oriented to what we're actually talking about and not sort of mixing things up. So cisgender and transgender, these are organic chemistry terms, the cis and the trans. Cis means same side as. So that means, in very plain English, your plumbing and your identity is on the same side. You feel it all kind of lines up. Gender diverse means literally anything other than that. It's a broad umbrella term, and it encompasses individuals who identify as trans, transgender, gender questioning, gender fluid, all the other gender identities in between. Gender dysphoria is literally the unhappiness some young people experience with their body. It's like on a very sort of mild end of the scale. You know that thing of when you get a really terrible haircut and it's bad. And every time you walk past the mirror, you go, oh shit. Oh damn, I forgot that haircut was there. You think you look a certain way and then you see the mirror and you go, damn it, that's the color I chose. Imagine that, but worse, and all the time. That is dysphoria. Now, you also hear the terms sex assigned at birth. Again, this is a plumbing issue. This means you were done born. The doctor, the midwife looked at your plumbing and told your parents this is a boy or a girl. Or if you were intersex, they were a bit confused maybe. So sex assigned at birth is what you were. People thought that you were based only on your plumbing. Gender expression. So a lot of these terms kind of sound the same, but they're not. Basically, gender expression is how you tell people about your gender. Now, if we think about it in sort of today's Western terms, boys, you done better wear pants, because if you wear a skirt, everyone gets real uncomfortable. But if you rewind a few hundred years, or you just geographically displace yourself to Scotland, or to certain parts of India, or to certain parts of the Middle East, you are allowed to wear a dress and everyone thinks that that's cool. Girls, generally, we fought long and hard, and now we are allowed, graciously, to wear dresses or pants, predominantly wherever we are. Gender expression is very culturally bound, but it's more or less like a clue to the people around you who you are. Intersex people are usually included almost accidentally in the transgender debate. Intersex people, this is a biological thing. There are hormonal or developmental issues. The biology doesn't all line up. Some intersex people identify as the gender ray, but they're raised that, others don't. I honestly can't pretend to tell you lots about intersex because those are not my usual customers. Trans, people describe their gender in different ways. Transphobia is usually, the phobia means that you're really scared of, but in this particular scenario, it usually means that you're being particularly discrimination, harassment, and abuse. LGBT, LGBTQ, LGBTIQ, LGBTQI+, LGBTQIAP2S, it's a whole alphabet soup. It's a lot. So we kind of go, we usually add in a plus after a certain amount of letters where everyone kind of just gets a bit tired. But you can see that it's just a whole bunch of people. So basically it's like anybody that's not cishet. That's a lot of people with a lot of different things. Because if we also think, look at the genderbread person, kind of nicely puts it all just in a picture format. Gender identity is who you are. Gender expression is how you look. Anatomical sex, that's the bits, the plumbing. Your sexual orientation is who you are attracted to. And it ain't got nothing to do with nothing. So a big thing that you kind of might have to do mental gymnastics around is that trans people do not always like people that are the opposite of them. So they might not identify as straight. They might have been straight and now they're not. So in your mind, do the gymnastics and uncouple the two. This is a person, this is who they like. So these are just, you know, like in a nutshell, some of the buzzwords that you might encounter. This is a very nice, besides the fact that it's a really nice slide and that the artwork was done by a gender diverse young person, Trans Pathways was a really, really great report that came out. And it was a community sample, questionnaires were sent out, and it was young people and their parents that participated in it. And it's just like the gift that keeps on giving. You keep on pulling new data from it. So it came out in 2017 and it interviewed 859 trans young people. So remember, trans can be as wide as the Lord's grace. So they were between the ages of 14 and 25. The stats around the mental health is pretty crummy. But it's pretty crummy for lots of reasons. 50% of all mental health conditions were going to start, if they were going to happen, they were going to happen in that age group anyway. So this is a vulnerable age group for the onset of mental ill health. And then on top of that, LGBTQ young people are at increased risk of mental ill health anyways, and higher level of psychological distress. But this is the clincher. It is not the fact that they are LGBTQIAP, any of those things. They are those things, and those things are okay. But it is how people treat them, and the continuous reminder that you are just not like we like our people. We like our people a certain way, and y'all just didn't fit in, so there's going to be constant nastiness. That is what raises the risk of the mental ill health, predominantly. Now, if we expand that a little bit and go, well, okay, this whole talk is about neurodiversity. Now, here you have to strap in, folks. 1 to 2.5% of Gen Pop in Australia has autism. In this Trans Pathways study, that was predominant, well, there was only trans young people, 22.5% of them reported a current diagnosis from an actual health professional. They also included a little screener, and then they caught an additional 35.2%. The screener that they used is the AQ short form. It's one that we are considering starting to use at Maple Leaf House. Well, we're kind of trying to figure out what we're going to do with it if we do know. So this is a fair bit higher. So if a gender clinic didn't reflect the outside world in terms of the neurodiversity of the population that attended it. So then people have naturally started wondering about this. Does the autism cause the person to be trans? Does being trans somehow cause the autism? The whole slide, this whole presentation is going to try and help you understand how these two things overlap. But literally the take-home message is they overlap, and that's it. They just kind of do. So don't lose sleep about trying to go, oh, which one's the chicken, which one's the egg, is all poultry. They just co-occur a lot. You look at the DSM-5T, the text revision, so the newest version, gender dysphoria in adolescents and adults, at least 6 months duration, at least 2 of the following. So an incongruence between your gender and the plumbing, a strong desire to be rid of either the primary or the secondary sexual characteristics because they just don't line up, that the shoe just doesn't fit. And a strong desire to have the bits of the other, and a strong desire to be treated as the other, to be of the other, and a strong conviction you have typical feelings or reactions of the other. So you have to have at least 2 of these. So this is a very broad definition. And then, as is everything in the DSM, everyone can have anything, but the clincher is the significant distress or impairment in social, occupational, or other important areas of functioning. Now, if you deep dive into gender, you might hit this cohort who kind of go, I don't actually 150,000% hate my body. It's just not the one I want. So you get different subsets within this cohort. The very, very super distressed, I want to tear my skin off, or the, ugh, so gross, or the, take it or leave it, but I'd rather leave it. And then I'd be happier for it. Now, if we look at the criteria for ASD, it's usually from early adulthood, like that, early childhood, like that's kind of the deal. And it has deficits across social and communication, and then the restricted repetitive behavior. Now, in the olden days, autism was predominantly seen as something really quite pathological. Young people and adults were seen as that they're broken or defective. They just didn't fit right, and they kind of needed to be kept away. And then they were kind of like, they don't fit right, but you know, we'll kind of let them play with us. And now these days it's kind of going, listen, folks, this is a natural variation of human neurocognitive function. This is not an innate disability. So that's a big sentence, because I'm sure we've all seen people on the spectrum that are maybe more, you know, if you want to be really kind of chill about it, you might go, well, yeah, we've all met someone who's kind of like Sheldon from the Big Bang Theory, and we've all probably seen young people and children and adults who are significantly differently functioning, who need lots more scaffolding to kind of be okay. So again, a very broad spectrum, but it is still something that occurs so commonly, it's kind of like accepted, like this is just kind of something that is. Society is constructed to suit the needs of neurotypicals. That is the predominant neurotype. Disabilities result when the autistic individual is required to consistently operate and function in a society wholly constructed for neurotypicals. Bright lights, loud noises, everyone talking. Why don't you just go and make some friends? You'll be much happier if you just make some friends. Why are you always reading a book? You know, like that constant thing is pretty annoying for a lot of people, but it would, for some people who are neurodivergent, it's like nails on a chalkboard. And if you live that all day, every day, and there's no way to switch it off, you're going to feel pretty crummy, which is probably why there's a high co-occurrence with depression, anxiety. I want to do things this way, but I'm constantly told I can't. So you kind of get a bit shitty, you know, like, so the fact that you're this square peg in a round hole and clothes are scratchy and the food tastes gross and everything is just not right. Well, kind of duh. Of course, you're not going to be a happy camper. Now, this is kind of like this slide, because the dominant paradigms around gender diversity is almost the same. The medical model focuses on disability and deficit. If you think back to how the DSM used to call it gender identity disorder, whereas these days it's the gender diversity model. Gender diversity is an identity. Society is constructed to suit the needs of cisgendered folks. Toilets are for boys and girls. The end. Besides the fact that they kind of left a whole bunch of folks out. Where do the intersex kids go? oh, we don't really care what your plumbing is, how do you identify? But not you. We care what your plumbing is. We don't care how you know, like it's just like these things just kind of swirl over and over again. So disabilities result when gender diverse individuals are required to consistently operate and function in a society constructed for cisgender folks, differing needs. So it's not so neurodivergence can bring its own baggage. Some of that is just because you're this square peg in a round hole. Gender diversity brings its own baggage. It is because you're a blue peg in a pink hole. But sometimes for gender diverse young people, it's also, I literally can't stand this. The skin that I'm in grosses me out. This slide is is one of the ways that they're sort of talking about being neuro-affirming. So you push for identity first language rather than person first. So you say autistic rather than a person with autism. I'm still working on doing that. And actually avoid saying autism spectrum disorder. You instead just use autism. I thought I was being super woke by going autism spectrum disorder, but some people might find that offensive. But you know, just how sometimes you will ask someone, what do you actually prefer? Do you want to be called Rebecca or Beck? This is the same principle you can use for people who are autistic. How do you like to be referred to as? If you have to write a letter that particularly is geared towards something like NDIS, the truth is that you're going to have to write the letter in a way that's going to make this person seem severely disabled. You are going to leave out any strengths that they have. You are going to write this from a disability and deficit model, because if you write a whole NDIS letter saying how great this person is and how much progress they've made, chances are they're going to lose a lot of their supports that they might still actually need to maintain that level of functionality. So if you're going to write a letter about someone and they're going to see it, my recommendation would be to talk to them beforehand and to warn them. Just give them like a trigger warning. Listen, this letter, it ain't going to be nice. I have to write it this way because of this, that, or the other. If you want a copy, I can give you one, but just know that these are the reasons why I had to write it this way. Neurodiversity is the umbrella term used to describe the natural diversity of human brains. Neurodivergent is the word that an autistic person would use for themselves, according to this paradigm. Neurotypical, not neurodivergent, and neurodiverse is like the everybody's. Yellow ladybugs is a very nice resource that I learned of recently, and they support the mental health needs of autistic girls and gender diverse young people. Their whole vibe is, in the olden days, a lot of resources were geared towards cisgender boys because the tests were designed for them, the treatments were designed for them, they were picked up earlier because people were actually looking. So they've clumped together sort of two large groups of people who were not on the spotlight before. You can just go ahead and download a whole free resource. So you'll see anytime I use a slide with some yellow on it, it's because I liberated it from the yellow ladybug site. Now, if you are neurotypical, you might have an idea of what gender identity, gender expression, and plumbing looks like and how those things overlap. And you might have done a bit of reflection and you might have gotten to a place where you go, listen, I didn't get it, but now I do. And then one day you see someone who is neurodivergent and gender diverse, and you go, oh crap, what does this mean? And then you think, and they tell you about their gender, and you go, oh, okay, this actually, yep, I get this. Yep, you want to be this. Yep, this is how you feel, and it just kind of makes sense. But then one day you might run into a young person who can't describe for you what their gender is. They're very unhappy about it. But if you ask them, how do you describe your gender? They go, I don't know. What would you like to look like? I don't know. Do you like how you look like now? I know. Which part? Tell me about how you feel about your body. I don't understand that question. And then you go, I don't understand. I don't know what to do with this. So keep that in mind, and then read this following really full slide. It's written by Bernard Grant, who is a neurodiversity advocate. Logical thinking is why small talk don't make sense to us, why many of us don't identify with the gender doctors and parents assigned us as infants. Autists, that's the word that Bernard uses, often don't notice social constructs. And if we internalize them, we tend to internalize them in unexpected ways that don't align with mainstream views. We're gender agnostic. We have no attachment to our physical bodies due to alexithymia and interoception, so like interpreting senses, variances. Neurotypical culture is concerned with physical appearance, and most neuromajority people attach their identities to their physical appearances, constructing their selves to align with how their bodies should look. Presenting today's society's gender expectations rewards people. Everybody knows the story of the pretty one who got away with everything. An autist's adherence to gender binaries is often a form of masking or camouflaging their autistic selves to blend in to avoid persecution. Autists are not as mysterious as society claims. Neurotypical simply lack insight into our culture. So when I read that, I kind of thought, that's probably like if you go to another country where they don't speak English, and you go, geez, what the fuck? I don't understand anything these people are doing. What the fuck's wrong with them? And I said, maybe that's what this person is talking about. And then I read some more about it, and autigender is a construct that is not mainstream. So this is like we've dove in deep now, folks. This person says, I'm Blake and I'm autigender. I use he, him pronouns. Autigender is a neurogender which can only be understood in the context of being autistic, or when one's autism affects one's gender or how one experiences gender. Autigender is not autism as a gender, but it is a gender that is so heavily influenced by autism that those two can't be unlinked. Doesn't mean that my autism is my gender, but it's a word that kind of like, sort of like it captures both. Gender is a social construct. It's a product of human society. It's a social system of categorization. Gender categories are closely related to the plumbing, and people are categorized into a number of options based upon the plumbing, how they look, and who they are. But these categories relate, how these categories look like vary between different cultures and time periods. Sometimes this person says, I struggle with understanding and internalizing social constructs. This extends to gender. I do experience gender, but not necessarily in any concrete terms that I can describe to someone who's neurotypical. Some people find their gender comes naturally and with ease. I struggle more to understand the ways in which I feel gendered and how I want to express my gender. Autism is not my gender, but it affects the way I experience it. It's a complex relationship. Different people might experience gender and autism in different ways. The important thing is to listen to and respect their experiences. If I am going really fast, it's because we're not doing questions now, and I'm trying my damnedest to get through all of these slides. So if any questions pop up, or if you go, what the, write it down, send it, and I'll try and get to it afterwards. Now, you may or may not have come across a lot of chatter and a lot of controversy, a lot of hoo-ha about gender medicine. Why do we treat it? What are we doing with it? There's no evidence. Everything's made up. We're all just gonna explode. The truth be told is that there have been large studies that have driven the direction that we're doing gender affirming care in. There are currently large studies underway that continue to support that direction, but we generally use a consensus model. So most of the people kind of agree that this is going to happen, and then you'll always get outliers. Recently, so this is in 2018, John F. Strang and colleagues came out with the initial clinical guidelines for co-occurring autism spectrum disorder and gender dysphoria or incongruence in adolescents. So this was a fairly big deal. They combed through any article that they could find, and they got gender specialists and people who work in neurodiversity and put them in a room, and then they fought it out. And last man standing was probably Strang. Second last standing, I didn't really think it was that bad, but they used the Delphi method, and they all explain it in the article that you can get for free on the internet, how they came up with these consensus guidelines. And these are the guidelines that we follow at Maple Leaf House. At the OSPATH conference last year, there was a chunk of the mental health component devoted to neurodivergence, because we're not blind to sort of like how things are happening. And I can tell you, a few years ago, if I had seen someone who was neurodivergent and gender diverse, I felt really uncertain, and I was worried. What does this mean? What do I do with this? But these days, and especially in a gender clinic, you see lots of kids. Those numbers that the Trans Pathways had with the 20-ish confirmed, 32-ish suspected, yeah, I'd pay that. The guidelines are that you kind of do the same things that you would usually do in gender affirming care, which is you don't rush it, you take your dang time. When I meet new young people at Maple Leaf House, I always tell them that my job as a mental health doctor is threefold. One is I talk to them, and in mental health, there's no x-rays, there's no blood tests. We've left the world of biology behind in a way. So I always tell them, okay, I'll talk to you. It's a clinical interview. I'll get collateral from your grown-up, because I work predominantly with young people and don't work with grown-ups. We'll put those together and we'll see, do the signs match up. If you have any other mental health provider that you see, they know you better than I do, because I'm just meeting you today, and then we'll get information from them as well. So we bring all of these things together. When the young person has many things going on, and that could be co-occurring mental ill health, it could be co-occurring neurodivergence, it could be co-occurring, I guess, other things, mental trauma, we have to do this. So you sit down and you can't just rely on what you see. You have to bring in what you hear. You have to bring in what you read. When it comes to young people who might have differences in sensory preferences, they may or may not be able to talk to strangers. They may or may not be able to make eye contact. They may or may not be able to sit down and have the good old-fashioned conversation. Is my job to make my room as friendly as possible to those kids. I cannot change the world around them. I cannot influence what school looks like, what the bullies call them, how many dogs are barking and scaring them, if their chicken has chased them. Sorry, I'm watching Big Bang at the moment, so there's a lot of Sheldon references in here. But I can control the room that I see them in. I mean, to like a certain degree. You know, you can get all these things, you can go nuts, but usually you see more than one person a day, so you can kind of do the best you can, but you can try and control it. So the ways that we approach the mental health sort of providers at Maple Leaf House approaches it is we most likely take more time. We use an extended diagnostic period. So whereas sometimes I can do an appointment with, you know, if the collateral comes and the parent in one appointment, because everything's already lined up and I'm just throwing the ball and knocking the pins down. But for some of the spicy kids, I have to take my time. And that might mean that I take my time, I try and understand who they are. And they say screen, I can very much. We don't always have screens. Sometimes people will bring in forms, or sometimes you just get that vibe. What I would do, or how it would look different in an interview is the young person would come and you would say, what do you want to look like? I don't know. How do you feel about your body? I don't know. I can't say. Then you might go, okay, can you tell me? So you break it down. Can you tell me, what do you like about your face? What do you like about your arms? What do you like? You break the body down into little pieces and you make the questions really concrete. You don't do double speak. You don't try and sound fancy. This is not where you're going to flex with your vocabulary. Not because they're stupid. It's not because these kids are dumb, but it is because they're wired different. Your job, my job, we are not supposed to be ableist. We are supposed to try and talk to them. And if you can't, then you get an interpreter. Mom, Dad, can you ask? Sometimes, even though we try very hard, the kid might just be someone who doesn't talk well good. And then we will send them home with questionnaires, like the gender preoccupation and stability questionnaire or some other questionnaires. I'll get them to send it back to us. Sometimes we also use, there's a very nice assessment model from Perth that relies on pictures, and it's like this whole graph situation, and you plot where you are and where you've been and where you want to go. So you try and you get all the tricks out of them. The principles of gender affirming care sound ethereal, but they're basically just be kind. Ask rather than assume. Ask people about their sexual orientation. Ask them about their gender identity. Ask them about their preferred name or pronouns. I mean, this will feel weird until it doesn't. I worked in gender medicine for a couple of years before it just started rolling out of my mouth that I'll go, my name is Yelena Goodyear, I'm a child and adolescent psychiatrist, but pronouns are she and her. It doesn't come naturally because it doesn't have to, unless you are gender diverse. Yeah? So you're gonna have to learn how to do this. The same way you're gonna have to learn how to do, the procedures that you do. You validate the person's gender identity. So you mirror the language that the patient uses. So if they say, I don't like my chest, and you're like, actually, I don't want to assume here, but I want to use the language, you might just say, with your chest, do you mean, and you might use your hands, or do you mean your secondary sexual characteristics? Like you have to soften your language sometimes for people who are really tense about these things. If you make a mistake with the patient, acknowledge it, apologize, and move on together. I'm sorry that I used that. I'll try my best to use the word. Let me know if I make a mistake. And then grieve in your own time. Oh, I'm sorry. Or, sorry, move on. And this is a tricky one. It's less tricky for me because I'm a mental health doctor. And my job is, like, I don't examine patients physically. I might do the reflex every now and then, but not really beyond that. So remember that anatomy does not define the patient. And this is going to blow your mind the first time you're going to have to do a pap smear on someone who doesn't identify as female. There you mirror their language. We don't discuss gender identity with other healthcare providers unless this is relevant to care. And transgender in room 3 has a cough. That doesn't have nothing to do with the cough. If the cough is the question, that's the cough. Like you don't have to say it unless you need to say it. You can say the person in room 3 needs a sputum culture for coughing. The person. Don't ask about transitional surgeries. Just don't. It's like this funny thing how we're just like wired to think about plumbing as soon as someone says that they're trans. Oh, plumbing. Oh, plumbing. Use someone's affirmed names and pronouns when speaking to them, even speaking about them to other team members. So don't do that thing of, Sally Smith. Okay, but remember Sally likes to be called Bob. But yeah, really, Sally, because you're going to do that 5 times. And the next time you see that person, you're going to dead name them because you've made enough neural connections between Sally and that person that you're going to stuff it up next time. So use opportunities when you talk about someone as practice so that when you talk to them, you don't stuff it up. Almost like when someone marries and they get a new surname, you're going to stuff it up, but you can try. You incorporate preferred names or pronouns into registration forms. Oh my goodness, IPM. can do this, but then every time someone goes to the John Hunter Hospital, it kindly gets reverted back. It's the bane of my existence. I mean, I have many banes of my existence, but it certainly is one of them. In a waiting room, in a group waiting area, call it last names only, especially if it's somebody that you don't know. And if it's a young person, you might not know if they've told their parents. So if you just go with Smith. The other day, I walked up to someone and said, "Are you Noah?" And it's like, "No, I'm really not." I'm like, "I'm sorry." The assessment process, besides now, you know, how you kind of zhuzh it up so that it matches who you're talking to, the rest of the stuff's pretty much the same. If someone is acutely unsafe from themselves or that it's an emergency, you do a risk assessment, you send them to ED, or you do a CAMHS referral. You assess their mental health, ask them who they are, and do their safety planning. You do that with or without them, preferably with them if they've got the capacity to do so. Managing an acute mental health presentation has got nothing to do with your plumbing, and it's got nothing to do with your preferred name. If somebody wants to hurt themselves that badly, your job is to get them safely there. You're not going to get any points by using, "Oh, this is Sally Smith, who I don't know, likes to identify as Bob, but we don't really think that that's a problem here now." It's Bob. Safety planning and risk assessment is tricky. You know, and I'm really looking forward to sort of hearing some of your examples. Not looking forward, that's a strong one, but I'm here for it. If you want to tell me about the hairy situations that you encounter, because I'm not gonna lie, I am now safely and comfortably embedded in a tertiary specialist clinic. Things don't get too dirty there. But from all the years that I spent at CAMHS, the shit hits the fan, you do the things. Doesn't matter who you're doing it for. So that would, I guess, would apply there. If somebody says, "If I don't get transition, I'm going to kill myself," focus on the last part of the sentence. Okay, well, you know, this is a process and we don't want you to die. So let's get you safe, and then we can talk about your things. If you do suspect someone has autism, do some screening tests, but for GPs, that might just not be your bag. So that's fine. You might just then refer them to someone. Godspeed trying to find someone. I wish I could give you a really good answer for that, but I can't. Gender assessment, send them to someone. I do really like to do it, and it also felt really weird for a while, but I like really lean into it, and I'll ask them, "Okay, what do you do? Who do you live with? What do you like to do? What school do you go to? Do you got friends?" Like, some of those questions sound really daft. If you're here like, "Tell me about your gender." I'm not telling you shit. I don't know you. So you kind of like just get to know them as a real person. So you ask all those questions because gender is one part of someone's life. The rest is this. If you focus only on this, only if it's an emergency, but if you're seeing them for the, you know, the referral, all of this is still there. So if they're going to tell you this part here, this gets sorted, everything else will be normal and wonderful and roses, you should be getting a bit sus, because no one, you know, gender affirming care doesn't solve all of your problems. So getting to know them as a real person helps in the here and now to establish rapport, but it also helps with treatment planning for the future. And who do you want to be when you grow up? What do you want to do? What are you interested in? These are good things also for people who do feel acutely unsafe, because if they can give you an answer, then that means that they're still partially tethered to the future. These would be the kind of things that we would do at Maple Leaf House. It's a multidisc team, so nurses, social work, clinical psychology, psychiatry, speech, dietitian, psychiatry, pediatric endocrine, adolescent physician, adult endocrine, sexual health physician. And none of us are particular. Like, no, I lie. There are 2 or 3 clinicians that have working experience, working knowledge of working in neurodiversity field. So they're really quite useful because they can kind of help suss things out. If we see somebody and they have lots of co-occurring conditions, we'll say, who else are you seeing? And we'll make a link to that person. But in our clinic, we can't treat it because I can't have any I don't have follow-up appointment capacity. But if we do sort of get a gleaming that there's other mental health conditions, we will write a letter back to the GP. And we'll link the young person in with supports. Sometimes young people who are both, who are neurospicy and gender diverse, they talk about this phenomenon of double masking. So that means that they're masking so that people don't see that they are autistic. So they're trying to, you know, look at me, I'm neurotypical. But then they're also kind of going, look at me, I'm a regular neurotypical girl. Imagine the amount of mental energy trying to keep that up. So you kind of wonder why they're anxious, and you kind of wonder why they're maybe a bit sassy or cranky or really, really tired. That phenomenon is called double masking. It's about trying to gauge what's happening here. What are the rules? What do I need to say here? You know, how do I do this tennis match of a conversation? Okay, now comes treatment. Okay, so assessment is one part, and then the treatment is the other part. So gender affirming care means we treat people with respect. You use their names, their pronouns, just like everybody else. And then gender affirming care does not mean you get what you want as soon as you ask for it. It doesn't mean that you walk in from the street, get your drugs, live happily ever after. Gender affirming care means if you are assessed as meeting the diagnostic criteria for gender dysphoria as it is described in the books, then you still have to tell us what treatments do you want. And then we have to assess, is that realistic? Are those treatments even on the table? The example that I always use is if a 10-year-old says, I want bottom surgery, I'd be like, shit, mate, I can write that down, but you ain't gonna get it because that's not even on the table. A 13-year-old wants hormones, that's not on the table. You know, so it is about what's on the table, which becomes available on different times, but it also depends a lot on your expectation. If the expectation is for a trans girl, I'm going to take estrogen and then I can get pregnant one day because I'll grow a uterus. That's not going to happen. Or the transgender boy says, if I take testosterone, I'm going to grow 10 centimeters taller. It's like, if your end game here is tallness, the T ain't going to give that to you. It's going to give you other stuff, but it ain't going to give you that. So potentially you need to go to Russia to get that experimental treatment where they break your bones and then they put the X-Fix on and then you get taller, you know, like how they did in the 80s. I felt that was like a bigger thing in the 1980s. So it is about what do you want? Are those options on the table? Are those options, is your expectation of this intervention realistic? And the clincher here is treatment for these conditions, treatment for gender dysphoria, the medicines. Do you do that? So it becomes really complicated because sometimes young people will be so unwell that their mental illness destroys their capacity in that given moment. But sometimes someone cannot get better until you've actually done their gender affirming care. That's really, really tricky. And we can't decide that in one appointment. Usually that kind of only comes out a bit later, like if we've seen someone maybe twice or so. If I can give you an example, I had 2 or 3 appointments with this young person. So one with the young person and the parent, the other one with the young person, and then a follow-up with the parent, and then one more appointment with them both, where this young person said all the things about how they identify, what treatments they want, and they, you know, said all the things because people know what to say. And then when I spoke to mom colored in the picture a little bit of somebody who has had significant developmental trauma, is currently really unstable in their sense of self, lots of presentations to hospital. Things are really just wild. By the third appointment, I managed to track down, in between the second and third, I managed to talk to the treating mental health team, which was a CAMS team. And they said we'd given this young person a diagnosis of BPD, and we've made all these recommendations that they be linked in with DBT, and we've made these referrals, and there's the long-term plan is DBT over yonder, and the short-term plan is DBT here. And then the psychiatrist has also started some medicine. And then I spoke with the young person, and you know, and we had a big conversation about, because mom said the gender identity fluctuates. Mom was like on board with it. She's like, I know this kid's not cisgender, but I don't know what they want from treatment. So we had a conversation about reversible and irreversible interventions, some of which, if you just look at age, the kid could have gotten the permanent stuff, but given the mental health condition and the fact that we have this history of flippy-floppying, I kind of lean towards do the reversible stuff, because the menstrual management will at least diminish your distress around your periods while you get your mental health sorted. So we're going to do some of the things so your mental health improves, so your capacity improves, so that when you are ready, you can make a gooder decision. But then versus another young person that I saw, almost the same age, whose parents, so I had one appointment with the young person and the parents together on their own, and then with the parents and the kid again. And the young person was really quite desperate to start puberty blockers, knowing that the one parent won't sign off on anything permanent. And in the process of talking to the young person and the affirming parent, we kind of put it together that this kid's mental health is taking a nosedive and the risk is increasing because the gender dysphoria is overshadowing everything. So then the treatment recommendation is this kid ain't gonna get better until we fix that thing. So there are so I guess the upshot is it's really complicated, and sometimes you don't have to say no, you just go, not the permanent one, get yourself sorted. But sometimes you do have to go, you do need to do the things, otherwise this person's not going to get better. The standards of care, so the World Professional Association brought out the 8th version of the standards of care. It is the mother of all documents pertaining to gender affirming care, and it is ginormous. But it makes it very clear that the consensus is co-occurring mental health conditions are always taken into account, but they do not need to be fully treated or absent, but they need to be stabilized. So in and out of hospital, in and out of hospital, in and out of hospital, you are not stable. You are not making good decisions because you are too unwell. So we would recommend that you get reversible things to try and bring the temperature down. But we wouldn't want you to sign up for Telstra in that time. You ain't never gonna get out of it. So we would want you to be a little bit more like, now, when young people say, I'm gonna kill myself, they're not stable. They're not making good decisions. They need to learn how to deal with their shit before you give them permanent things. And know that there is always a non-permanent option. Everyone's like, gender affirming care means you cut off the penis and you give the drugs. No, there's so many other things. So just, take a breath. We can talk about that more. Parental consent requirements in New South Wales. I'm hoping that you can get this download. I tried a couple of times and I kept on just saving it to my drive, but it's from the Inner City Legal Centre. They've got really good handouts for virtually anything. New South Wales. In New South Wales, young people who are between the ages of 15 to 16 may access testosterone or estrogen if they have the diagnosis, they've demonstrated capacity to give informed consent, and they have a realistic expectation of treatment, and both of their parents have given consent, and NCAT has said yes. The NCAT one kind of like snuck in there by some higher ups in the government, And it is all about fertility, and it's been really frustrating. So that's why it kind of gets a bit messy between 15 and 16, not because the medical recommendations are messy, not because we don't kind of think so, but because NCAT is worried about fertility. Over 16, NCAT is like, ugh. So yeah. But then even if over 16 you need the diagnosis, you need to demonstrate capacity to give informed consent and a realistic expectation, year-old gilly competence, and you need parental consent from anyone who has got parental responsibility. While that is absolutely lovely on paper, it becomes a shit show for young people who have escaped domestic violence, because that, we all know, all the paperwork might not have been done in that case. So then that kid keeps on being hurt by the parent that hurt them, because that parent, they're too scared to tell them what's going on. They're too scared to even tell them maybe where they are, but now they suddenly get a vote in treatment. The parent who's missing in action, the parent who's never been involved in the kid's life, the parent who is just like in jail. Like sometimes it has created significant difficulties for us, because inevitably you have to fight really hard to try and get something. And of course, that's going to worsen someone's mental health regardless. Regardless, it doesn't matter what your diagnosis is. If you need something and someone is actively going, well, no, or you can't get it because the person who is absent from your birth certificate has the same right to you as the actual parent who raised you. Shit, that's really frustrating. So that's very difficult to manage. The pros are that as an adolescent, and that's got nothing to do with diagnosis, neurodivergence, anything, parts of your brain's not online. So you kind of borrow your parents' brain. So it makes things easier in a way that we can kind of go, this is a whole of us decision. And most parents care about their children. I'm not going to say anything about the ones who hurt them or the ones who are missing in action. I'm talking about the people who are actually there. But yeah, that is probably one of the most unpleasant parts of my job, is to try and, I don't know, magic a parent out of nowhere. I've spoken a little bit about informed consent. So informed consent means that really, for all the queries about, they're teenagers, they can't give informed consent. They really can, if you just do it right. So you do need to explain to them what they got. You do need to make them aware of what their treatment options are. All of them, not just the ones you like, or the ones that they come and ask for. Oh, I want this hormone. You can't get it. You need to make sure you know all of your options and which one's actually the best one for you. So we talk about the interventions, that what they ask for, like, kind of contradicted myself there, because I said principal gender affirming care means that you don't get what the doctor tells you to get. But I'm talking about that in the sense of an options that are not on the table. So if a 14-year-old rolls up and says, WPATH guidelines say that I should be getting estrogen, I'll be like, yes, they do, but that's not on the table for you here. You're not wrong, but it's just not available here. So you talk about all the options that are available. You make sure they know the effects, reversible and irreversible. What are the side effects? What medical monitoring? What's the impact on their mental health? What is going to happen to their sex life? I have had magnificent conversations with young people about their sex life, and it is never not funny to see them cringe, and to see me cringe, and to see their parents cringe. I give them lots of warning. I say, we're going to talk about it, and I try to ham it up a little bit, but the point is, I need to tell them, what is this going to do to their plumbing? Who do they like? Are they going to be able to have sex with them now or in the future? And if they don't, they need to let us know. And that's going to be hella uncomfortable, but if they don't tell us, we don't know. And it is a process. It's not a one-off, because the education happens over many sessions. You can stuff up informed consent if you make wrong assumptions about what people want. You do an incomplete assessment, like someone doesn't have gender dysphoria, but you give them the treatment. You don't manage the co-occurring conditions properly, or you give them the wrong information about their treatment. I have to ask all these children What's going to be different in your life if you get this treatment? What's going to be different in your life if you don't get this treatment? Is anything that you've heard made you go, shit, that side effect is too much. I don't want to do this anymore. I talk to every single kid I see that it is okay to change your mind. If you start on gender-affirming medicine and you don't like it, we will not fire you from the clinic. We will not kick you out and lock the door. You can still come. Just let us know, and the medical doctors will give you a recipe to come off of your medicine and check your bloods and make sure you're okay, and we can talk to you about your feelings. You are not locked into a contract, so that they know that even though we've tried our best to predict as much as we can, sometimes people try it and they don't like it. So it's talked about this like in bits and pieces. Social transition 9, the infinitely reversible things. Literally the only thing that's on the table for anybody under Tanner stage 2. Under Tanner stage 2, that's all your ass can get. Social transition. What's your name? What pronouns do you wear? Clothes that you want to wear. Get the toys that you want to do. That's it. You don't push them. You don't pull them. You use like weight, because they have a higher chance than anybody else to change their mind. But if you push them in any direction, you will never know. Medical transition, the reversible and the irreversible, and then surgical transition. The reversible interventions are things like, menstrual management or puberty blockers. The irreversible ain't really irreversible, but it's partially. So that would be like testosterone, estrogen. Not all trans people want all the things. Not all trans people define their transness by how many interventions they've had. That is a fact. And that is sometimes really like, what? Until you see it a lot and you go, okay, there's not one way to be trans. Not all, probably about, so these were stats from the trans pathways. And other stats have also sort of mirrored that. Sort of about 30% of people who come to a gender clinic want medicine. It's not everybody. And we do this because we have enough evidence to say that they do better. They do better when they do better if we actually give them, help them feel more comfortable in their skin, and then they stop worrying about their gender all the time of all the day, and they can actually get back to doing the other things. Remember how I said, this is your gender, this is the rest? They can get back to doing that. Get their ass to school, make some friends, get a hobby. I'm gonna do an exercise, play with a dog, do the other things, be a whole ass person. So role of GPs, y'all are first contact. I tried to get a really like sci-fi kind of a picture, but apparently there's a Star Trek that's called First Contact, so all I got was Star Trek video posters. So you now got the generic doctor sitting on the chair talking to a young person on the bed clip. Most of the time, young people feel really supported by their GPs. Sometimes the things that do come up is that they worry that they need to educate the GP that the GP doesn't know, or the GPs that do know, they're booked up until kingdom come. And the thing is that there is no specific curriculum for gender-affirming medicine. There's no psychiatry curriculum for gender-affirming medicine. Standard issue psychiatry training has zero in about gender identity development. Standard, so I'm a generalist adult psychiatrist and I've done subspecialty training in child and adolescent psychiatry. And I can tell you that there has been zero training as part of my standard curriculum on gender identity. I sourced it. It was my special interest project as an advanced trainee. So I had to go looking for it. So if I had to go looking for it, I can only assume that you had to go looking for it. So if you don't know it, people get frustrated, but it's like, sorry? This is not the movies where the one doctor can do everything. You know, in the movies, there's a fucking pathologist who works in a lab, but the apocalypse comes and then suddenly they can do brain surgery. Shit, I want to be that doctor, but I'm not. So you can learn the things. That's the point. You can learn the things. This is a terrible quote, but I put it in so that we can see that for some people it kind of goes really south. The first GP I spoke to refused to treat me at all, even for services unrelated to my transition. I tried many other GPs before one was willing to refer me to the only GP who was willing to provide transition-related services. This GP was excellent, but servicing the entire trans population of my city, so I had to wait over 6 months. Finding a good GP is very difficult, and a bad first experience can set you back. This is true. For psychiatrists, any kind of doctor, it is very, very hard. And with the insurance company, with MDI going, we are not providing indemnity for GPs who start hormones. It's like such a fucking red herring, because who even does that? But I know of maybe 2-3 times that the GP that has referred someone to our clinic, when we write the letter back, the GP calls and says, I'm not going to see this person anymore for like literally anything. So pretty kind of parents. Somebody asked a question earlier about what can you do with these people, with these young people, if you see them and now you know where to send them to, but it's like 100 years. So my recommendation would be, good luck. If you can, maybe see them like, every 3 months, even if it's just like half an hour to kind of just touch base. If you find them and you think that they would benefit from mental health treatment and stabilization in some kind of capacity, do the 2 referrals, because Maple Leaf House, we can't do therapy. We're not funded for it. Literally, mate, if we had to do therapy, our books will be closed like it is closed everywhere. Currently, we can only see people, but we can only do assessments. So if you see a young person and you think, send them to the psychologist for the treatment. Treat their mental health condition if you can, and then refer them to us. And if you can, check in with them sporadically. No, everyone's busy. A big thing that could be really helpful is linking them in with community supports while they're waiting, so that they're not in limbo. Limbo and good. The Catholics were onto something when they went limbo is bad. Limbo is very bad. Kids do better when their parents like them. Mate, that's true for like literally anything. So if you're like, I don't know what to do, link the parents in. Get the parents somehow, because the parents see the kid all the bloody time. And usually a lot of energy is spent on making sure that the kids are okay. Okay. These kids are attached to parents, so you're not going to waste your time or energies if you look after them as well. Transforming Families is a primo resource, and Transcend has got a parent hub. This article, The Lived Experience of Parenting a Transgender Child, is phenomenal. I've put in a little link because it's behind a paywall, but there's a free link. It actually walks through, it's almost like, those 5 stages of grief. So these parents, so they just interviewed these parents. These were all parents and their kids were grown-ups, but they talked to them about what it was like when their kids came out, and how difficult or undifficult it was, and how scared they were for their mental health, and how scared they were to navigate their friends and family. It's a parent thing, and it's really quite lovely. So yeah, basically in gender affirming care, we use the consensus model of practice, because watch and wait, there's no evidence that it works. And if you really want to go, but what about if they grow out of it? If they were going to grow out of it, they would have grown out of it the 1 year that they wait to see somebody. No, they don't. And psychological therapy to uncover the cause smells like conversion therapy to me. But honestly, I don't know enough about it, because gender affirming care has got the evidence, and I've done it now for 9 years, and it does the kids good. They feel better afterwards. And I've had kids who change their mind. But predominantly, I do it because it's really, really nice to see them be happy. So yeah, there we go. And then lastest slide is check in with yourself. If you go, you've done now this whole talk and you've listened to me and seen me gesticulate wildly and you go, yeah, no, I'm out. This is not for me. That is okay. You know, that is okay. That's fine. But check with yourself before you read yourself. Check yourself and go, no, I'm out. And then refer them elsewhere. You will do significantly less damage to yourself and to the people that the community that you care for if you go, yeah, no deal, but you can go there instead. So that's okay. And that's it. I don't know how to get all the pictures back. Yeah, but that's me, and I'm done. I'm gonna drink some water. Gordon,
thank you so much, Lovely. That's awesome. Okay, it's great to hear another person.
Okay, there's more people coming back.
Thanks for that, Yolandi. That was great, and so many gems there. You know, obviously we get you know, these patients often quite distressed, and you know, it's in a 15-minute consult, and you've given us so many tools just to help provide that patient-centered care. So thank you.
Georgia, do you want to hear something? Do you know how long my initial appointments are?
How long?
It's 90 minutes. It's 90 minutes.
Oh wow, I would love to have that.
So, dude, I don't know how you do the things that you do, because 90 minutes isn't long enough sometimes. So you do such a great job at screening for a bazillion things in a hot minute.
I think the important thing there is, yeah, patients do come in quite distressed, and if we can just, as you say, acknowledge and validate what they've come in for and explain it is a process, we'll help them through it, but it's not going to be all done in 15 minutes, but it is a process, and certainly you've helped us with that. There are some questions here as well, so we might go through some of those. Or the first one was a very positive comment. We are so lucky to have Yolandi for our kids. I'm so grateful that we found her in our lives. She's been absolutely outstanding in the care of my neurospicy trans daughter, and we are very grateful for helping us navigate everything.
The kid, like the young people like it when you say spicy. Like, not everyone's the same, but I've had 100% success rate with spicy. So if you're like, oh shit, I don't know what word I should use, you just go with spicy, and everyone will go, I get it.
Right. And I'm just trying to move down the questions. Someone commented about GQASC is also a good screener for picking up more female presentations of autism.
Oh, okay.
So, not sure if
we are
that's
working at Maple Leaf House. So at Maple Leaf House, we're working on setting up a set of questionnaires that we're going to be rolling out, that everyone gets those. So I'm just going to write that down because I'm in the market for information. It is the what now? The
GQ.
Yep.
ASC.
Okay, cool beans. Thank you.
And another question was, does using wheel of emotion help in these cases where there is alexithymia, which I wasn't familiar with that term, so I had to Google it, which means emotional blindness.
Okay, alexithymia I get, but I don't know the wheel of emotions. I usually dude, I've got 90 minutes, so I can sit with someone and pick up the vibes. So I struggle using lots of tools. Like, I'm not a very tricky kind of person. So but if you find a tool that works for you, go for it. I use lots of, like, write it down, draw what you're feeling, those kind of things. But usually also I see teenagers, so they have picked up a few words here and there. It's been really interesting. Some kids, you see them, they do better in person. Some kids do better on the video. Some kids do better on the phone. So again, I've got the luxury of mixing it up. If you want to use a tool like Wheel of Emotions, go for it.
Yeah, personally wise, working in Headspace, we do use the emotions wheel a bit, because I think a
Yeah.
lot of young people themselves do have troubles putting words to what their actual emotions and what they're actually feeling, and often are quite scared and overwhelmed by that actual idea about what am I actually feeling, what's actually going on in my body, what's going on in my brain. So that often actually helps, because the actual emotions wheel itself actually breaks down these words in different sections, and what is the base emotion there that comes back down to. And that often actually helps to actually conceptualize, oh, am I just feeling sadness, or am I just feeling a bit more of this kind of grief, or is this lost kind of feeling I'm feeling, or am I actually feeling happy, or is it actually really ecstatic, or am I actually more actually feeling a bit content, and therefore being able to actually put more of these kind of connotations and terms to it to describe themselves a bit more. So yeah.
Dude, that sounds lovely.
Hmm.
I'll have to give it a look. Thank you.
And the next question probably isn't as common in your work, Yolandi, because you're actually seeing people with gender dysphoria, but how do you navigate the backlash or phobia when asking for people's gender or sexual identity? So again, you know, in general practice, if you ask, they might say, you know, especially with cisgender people, then they might be like, why are you asking me that question? They might be offended. So how do you respond with this or use it to educate?
Dude, that is so hard, isn't it? Like, when I work in my private practice, it's like a whole mix of kids. Sometimes I do get some clues from the referral, you know, sort of what's going on, and then I can adjust myself accordingly. I must admit, I've not actually ever had like backlash when I've asked these kinds of things.
Mm.
But again, my customer base are Gen Z, and they live for telling you their pronouns. They love that shit. They love themselves a good label. So I would wonder if a workaround would be using maybe more like just like a standard issue form that you fill out, you know, so that way you don't have to put yourself out there and ask. But I would wonder, Gordon, at Headspace, where you would see all sorts of customers. Do you have a
we definitely do. So we definitely actually ask for gender side of things, and I know of one person I met recently who has said, "Oh, for F's sakes, like, I'm a dude for," kind of thing. And and it's like, well, the thing is, I guess. It is really important to be respectful, of course, to actually ask as well, and if you don't ask, you don't know. And one of the things I personally do all the time is try to normalize it and say, oh, a lot of the people who come into our service do identify as a different gender to what they were born to. So so do you have a preference? Do you prefer a certain name, or do you prefer a certain set of pronouns? Just to make sure we make you feel more comfortable using our service. How can we actually do that for you to make you feel more accepted, more included? And and most of the time, people tend to actually be okay with that.
Yeah, I suppose it's just like, sorry.
That's so I will also, if I meet a new young person, I will just go, my name is Yolandi, my pronouns are she and her. And then, but I go a bit over the top, where I go, okay, what pronouns do you use? How do you describe your gender? Because I don't want to make assumptions about you based on how you look, you know, so I can do a little bit of a dramatic spiel about the whole thing. But again, that is because I literally know what my customer is there for.
Yeah, absolutely.
Otherwise, why are they here? I'm here to tell you I'm cisgender, and I'm really happy today. It's like, shit, you lost.
I think also as well too, I think staff members wise, if we do actually have gender badges on, that often helps. So this is one of the badges I normally wear to work. So it has my name on it, has my he, him pronouns. I'm wearing my other one there saying I'm an ally for the LGBTIQ+ community. And I think sometimes having something like that to break the ice can definitely make it so much easier to bridge those conversations, which may be a little bit spicy, a little bit more uncomfortable for some people.
Yeah, and it's again, if you come from a predominant neurotypical cis-het paradigm, you don't have to do these things. So it's just about knowing, I'm doing something that I am doing differently.
Yeah.
I've got another question here. Is there a clear preference for what you use for period suppression prior to seeing you, such as a combined pill or just progesterone? I know
So So I can answer that one the way that I do most of my medical education. I am a psychiatrist. I know a fair bit about these medications, but if you've got specific questions, you do need to go and speak to a medical doctor. What I have gathered from talking and listening to the actual prescribers is level and any of the like combined ones will get the job done. So you ask the young person, listen, what do you want? What do you want? Because if they go, because some trans boys or MBs, like some menstruators will be like, I don't give a shit, I just don't want to get my periods. And then you can go, okay, cool. Then then that opens the decision door to basically doing whatever combined oral contraception that floats your boat. But you do know, but you have to tell them you're going to get feminizing effects with this because it's got progesterone in it. Whereas if they go, I literally cannot, please don't, I can't deal with any feminizing effects, just shut it down, then I would sort of talk to them about Primulet, because at least that doesn't have that feminizing effect. If they're feeling particularly bullshit, then we will go, you know, like an Implanon or a Marina. The endocrines talk about that a fair bit. But I think, you know what, and I'm not just saying this, the kids who come to see us where their GP has already started some kind of menstrual management for them are so much better than the ones who don't. Like, it's just you've taken that one worry away. Like, it's just, oh my goodness, thank you. So whatever you all are doing, when you do it, they really like it. The kids are fans. So so those are usually the two that I would talk about in my capacity as a psychiatrist.
Yeah, normally speaking wise, I know from my practice wise, Primulet tends to be the most common I've seen around. So so of course that was probably my go-to. But if they are keen for something more definitive, then of course your Implanon, which lasts for 3 years, or Marina as well too, they tend not to actually like Marina because it's so invasive, and actually putting it in can be quite overwhelming. Theoretically speaking wise though, I believe your Depo-Provera is meant to be one of the best ones for creating amenorrheic states. But the trouble though is our bone density for young people, and we don't want to actually be causing this person to actually shift into an osteopenic state or actually lack the actual bone strength for the future. So that's the reason why it's something like I tend not to actually use for young people, but it's actually one of the best ones for creating that amenorrheic state.
Yeah, great. Yeah, and I've got some patients on Implanon, but obviously it's just like with, you know, contraception in general, it's patient preference. But yeah, it's certainly something that does induce that amenorrhea is yeah, much more popular. Are there any resources for nurses who might be giving puberty blockers so they can feel more prepared when a young person presents after being seen at the clinic? So if they're seen through Maple Leaf House, given the Riandron script, and they come to the nurses for the injections, are there any resources that you recommend?
I would imagine there are lots, but the nurses, the CNCs at Maple Leaf, that's their jurisdiction. I don't know anything about it. There might be some, I'm going to handball this one to the Health Pathways folks. Maybe they know more about those. But if you, I promise you I will not remember, not because I'm an ass, but just because my brain resets after a while. If you send me an email, I can, or if you send an email to Maple Leaf House and ask for Liz or Mel, they'd be able to give you all of their resources. They're awfully friendly and super keen.
Yeah, oh, that's a nice segue into Health Pathways.
Well, I'm just going to show you where the androgen blocker information is to start with. Oh, can you hear me? Am I off mute?
Yes, we can hear you. Yes, thank you so much.
Great, fantastic. That's all right. I'm launching into the middle of what I was hoping to say, and I'm sorry to jump in. There's just so many things that you've just spoken about that I just thought, oh, I need to show you where that is on Health Pathways. And that the androgen blocker information is on the gender affirming hormone therapy page, and this is the one that we've got there as a bit of an information fact sheet. So, but just starting at the very beginning, here are the login details, and please, I encourage you all, if you've got your phone or your iPad, to log on and have a look at Health Pathways as we're talking, because you get to know Health Pathways by playing with it. So if you're on the Central Coast, you're on the right-hand side. If you're Hunter New England, you're on your left-hand side. The clinical pathways are exactly the same. And all the information that we have for patients at the bottom of the page is also on that patient info website, which is not password protected, and you can give that to all your patients and they can go and freely access all of that information. But I just wanted to spend just a couple of minutes telling you about this fantastic suite of pathways that we now have for transgender healthcare, and Yolandi was involved in this. We have here in Hunter New England written the New South Wales lead region pathways, state-based pathways for transgender healthcare. We did this with a working party of, I think it was 13 or 14 clinicians, and they represented primary and tertiary care across metropolitan, urban and rural areas, from the specialties of endocrinology, mental health, sexual health. Who else did we have, Yolandi? I felt like the pediatrics. And so everyone got together and developed this suite.
Yeah. Social, like everyone.
Yeah. So and they are all in line with the SOC8 guidelines, and Yolandi was particularly helpful in the adolescent pathway. So there are 3 pathways. There's the transgender health for adults, the transgender health for children and adolescents. Oh, let me just show you this landing page. This will be easier. Is that big enough, or do you need me to make it a little bit bigger? It's big enough?
That's fine.
Okay, so there's the adults one, the kids one, and adolescents, and then there's a separate one which is just around the gender-affirming hormone therapy, and then we've got the referral pages. Now, these 3 pages don't change across New South Wales. If your health pathway community, which Central Coast has attached to them, they're there. The main subject matter expert was the wonderful Dr. Katie Wynn, who I think we all know and love very much. She's just a powerhouse of passion in this space, and I think before we had this particular pathway, I think the last one got updated 38 times in its little short life from 2017 to now. So they're very agile. When things change, when guidelines change, when new information comes along, they get changed very rapidly, and that change now can spread across New South Wales because we've got people attaching to this pathway. I'm just going to show you some key features in line with what Yolandi was talking about for the transgender health kids and adolescents page. They're set out like all our pathways are, starting with red flags, assessment, management, referral. Some of the things that Katie was talking about, that Yolandi was talking about, what's actually on the table for these kids. So to support you in having those conversations, we've got some little bit of information about treatment options that you can discuss with patients, and what's on the table for particular ages. Yolandi was very, very helpful in writing this legal requirements drop-down box and all the links that were in that. And then just moving down into management, some of the things that we talked about. What was the other thing I wanted to show you? Oh, the social transition. So talking about social transition for those kids where that's what's on the table. There's some ideas that we've got there. And then and then contraception. We've got some contraception information, and then the medication to suppress menstruation. That's in management 7. So pretty much all of those questions will be answered for you in the health pathway if you go and jump on and have a look. Down the bottom of the page is some further information for health professionals and some further information for patients. And the one I'd really like to draw your attention to, which is also on the sister site patient info, is this transgender and gender diversity page from Maple Leaf House, which has got some excellent resources. And particularly, you were talking about feeling supported in the GP appointment. There are some resources that they can print out to take with them to their GP to help them have those conversations. And then just a quick little show of the referral pages, because I think there's one, if you, as a GP, you're not feeling completely comfortable and you want to send them off to a different GP, as Yolandi was talking about in her last slide, you can go onto the TransHub Gender Affirming Doctor list and you can find GPs in your local area. And if you're looking for how to get in touch with Yolandi, get your patient onto Yolandi's service, or get in touch with Maple Leaf House at all, the Maple Leaf House referral information is all here. And so thank you so much, Yolandi, for that amazing presentation.
Sandra, you're
a powerhouse.
very kind, thank you.
And I think that's all I wanted to say. But if you've got any questions, please, at the bottom of every page, there is a send feedback button. And I'm actually going to show you something really cool, which we only discovered recently. But if you press Control F, and if you're looking for medication for menstruation and you type menstruation in there, that'll take you straight there. So Control F, anything you're looking for, if you're thinking, oh, what's the deal with contraception in these patients, you know, you have to spell it properly. There you go. So Control F is your best friend when you're looking at health pathways. You might have to, the other best friend you have is the Expand All box, and that will open all the drop-down boxes. And then if you Control F, you will definitely find what you're looking for. I'm going to stop sharing my screen. Thank you so much for this opportunity to launch these amazing pathways that this fabulous team of very dedicated and passionate clinicians have all been a part of. How do I stop sharing my screen now?
Thanks,
I've already done
Sandra.
it for you, Sandra. It's all,
Oh, you've
all
done it. Thanks so much, Sydney. Over to you, Erica, I think. Is that right?
Thank you. Yep, I'm just about to share my screen. Can you just confirm that that's sharing okay?
Yeah, we can't see anything yet.
Okay.
It just went away, Erica. I'll resend you the request if you can't find it. Give me 1 second. I'll do that for you. There you go. You should have another prompt to help you out there.
There we go.
Perfect.
I've just clicked on that. Is that working now?
It is. Yes, thank you.
Great, excellent. Okay, so yeah, I just wanted to cover some additional information specific to the Central Coast, particularly just regarding other pathways that are relevant and the referral information. So yeah, I'd like to acknowledge the Hunter New England Health Pathways team and Hunter New England LHD subject matter experts and all the other contributing subject matter experts and GPs who contributed to the transgender pathway working group as well, as Sandra said. So yes, Central Coast has attached to the Hunter New England lead region clinical pathways, the clinical pathways that Sandra referred to. And then we've got the two local transgender health and gender diversity specialised referral page and the support services referral page. So on the specialised page, we've got lots of information about obviously the specialty services, mental health, endocrinology, and so on. And then on the support services page, we've got more of those social and non-government organisation and other sort of support services that you can link your patients in with. Also, we've got the autism spectrum disorder pathway and then obviously the youth mental health pathways as well. So those are available and may assist you as well in managing the co-occurring mental health conditions in this population of patients. And then there's also the self-harm, the eating disorders and the suicide related pathways as well. And I'll just click over to my next slide. Sorry, it's just a little bit slow. There we go. And regarding referral information specifically to the Central Coast, there's the related child and youth referral section with the mental health related referral pages for child and youth. There's the clinical pages, the specialty pages, and then there's also the non-clinical community mental health support. So again, that's more of that social support and the non-government organisation support. Then there's the general mental health referral section as well regarding urgent referral in all ages, psychiatry assessment for all ages. Then there's eating disorder referral information, and then we've got eating disorders advice, mental health helplines. And then in the community and social support section, there's the social prescribing support page as well. So that's covering more of the social determinants of health, other supports that GPs could link their patient with so that they're fulfilled in other areas of their life, covering more of that social aspect. So yeah, I'll just stop sharing now and we can perhaps go back to questions. Welcome questions specifically about health pathways, but also there's time for questions for our presenters as well. Thank you.
And just a reminder to everyone as well, we have uploaded both the Central Coast and Hunter New England slides from tonight as a handout. So if you wanted to download that, so you could click on the links directly, please feel free to do that. It will also be uploaded with a recording of this video in the Education Library. But if any other questions come through, let's just have a quick look. Nothing has come through specifically for health pathways, but I did want to personally say as well, that was a wonderful presentation. And if I can quote Yolandi, it was super spicy. It was just great. So thank you from all of us. And I probably will definitely be
my children particularly die a little bit on the inside every time I use a word that is of their generation. So I literally try and use a word of their generation every single time I can. So I throw words around like, oh, the vibes are just off, or ew, that's too spicy, or that's not chuggy. And then I just sit back and watch them implode. Fuck it, it's a lot of fun. I would recommend you all do that. So thank you very much for calling my talk spicy. I do. Thank you.
Thank you. Thank you, Dr. Goodyear.
Thanks,
Amazing.
Olivia.
No questions, so we will wrap up for tonight. And then just a reminder, there is the evaluation that will come to you. And again, we would love you to fill it out to give us feedback on this amazing presentation. But thank you all for your participation tonight. We really enjoyed it.
Thank you.
Thanks,
Thank
guys.
you so much.
Thank you, folks. See you. Bye-bye.